Welcome to Presentation 7 on Paying for Healthcare. I am dividing this presentation into two sections, the problem and the solutions, or potential solutions. The problem has three parts: rising costs, poor outcomes, and unequal access to healthcare. As far as solutions go, I want to look at the Affordable Care Act, more commonly known as Obamacare or ACA. I also want to look at some alternative systems, because no one expects that the ACA will be the end of the healthcare debate or solve all the problems we face. So in this presentation, I'll be contrasting the way the US is heading with the ACA with the Canadian and UK systems. Your textbook also discusses the French and German models, but you don't need to know these. So, the problem: rising costs. Healthcare costs are rising much faster than inflation. This is causing serious problems for every major institution in the United States, from the federal government down to local governments, and from big companies down to mom-and-pop companies. The yellow line on this chart is the Consumer Price Index. It represents the cost of a representative sample of all the goods and services sold in the U.S. The black line is just the price of medical equipment and services. As you can see, healthcare has been rising increasingly faster. Healthcare costs have been rising increasingly faster than inflation since the mid-80s. Actually, there are two aspects of the problem of rising healthcare costs. The first is the increase in prices for aspects of healthcare. This is what was measured by the Consumer Price Index in the last slide. Here we are talking about the cost of a fixed unit of healthcare, like an aspirin tablet. The previous chart showed that the price of something like an aspirin tablet has been rising faster than inflation. Another important aspect of the rising cost of healthcare is the increased proportion of the amount of money spent every year that goes to healthcare. In the past, the biggest expense for a family might be something like food or rent. For an increasing number of families, their biggest expense is healthcare. The increase in healthcare expenditures is not just due to an increase in healthcare prices. It is also occurring because we are buying more healthcare. Individually, the pills we buy are more expensive, and we are buying more of them. A good way to think about this is in terms of GDP. GDP means gross domestic product. GDP is the amount of money that gets spent each year in America. This chart shows healthcare expenses as a portion of GDP. My source for this data is the National Health Expenditure Accounts produced by the Center for Medicare and Medicaid Services. As you can see, the amount of money we've been spending on healthcare has been climbing steadily since 1960 and is now over 17% of GDP, which is higher than any other nation. This is important because it can bankrupt many important institutions in American life, starting with the federal government itself. Any institution that has to pay a portion of people's health care, large corporations, the federal government, state and local governments, or for that matter, community colleges, all these institutions are confronting prices that are rising too fast to deal with. This was all made clear by a report from the Government Accountability Office, or GAO. This is a nonpartisan part of the government that keeps track of how government money is spent and whether it was spent effectively. In 2008, the GAO produced a report called The Long-Term Fiscal Outlook. And the bottom line for the long-term fiscal outlook is that the federal government is going to be broke if healthcare costs are not controlled. This chart from the report breaks down federal spending into interest on the debt, Social Security, Medicare and Medicaid, and everything else. Here, the everything else includes all the things that we expect the government to do. Defense, federal highway funds, the EPA, the NIH, all that stuff. These are all represented by the different shades of gray in the vertical bars. The black line is the estimate of how much money the government will take in, barring drastic changes to the tax code. What we see from this chart is that over the next 20 years, spending on Social Security, Medicare and Medicaid, and interest on the debt will crowd out all other spending, with Medicare and Medicaid accounting for the lion's share of the growth. Increased expenditures on Social Security or on any other entitlements or government functions are not a big part of the problem. It is just healthcare expenses. This is another chart from the GAO website, but not from their 2008 report. It shows the composition of government spending in 1966, 1986, and 2006. In 1966, during the Vietnam War, defense was the largest component of federal spending. Medicare and Medicaid was a tiny sliver, about 1%. Now, defense spending is about equal in size to spending on Medicare and Medicaid, and this was in 2006 when we were fighting 2 wars. This is not because defense spending has gone down, but because healthcare spending has gone up. So why are healthcare costs going up? Here's a list of 6 reasons I have gleaned from various medical ethics textbooks, the media, and healthcare activists. I'm not claiming any special insight here, and I think most people involved in the healthcare debate will agree that all of these are factors. The first reason healthcare costs are going up is that medicine itself is better. There are better technologies, there are better therapies. We have moved from imaging the body using simple x-rays to using fancy MRI machines. We used to be able to do nothing for extremely premature infants. Now we have NICUs stocked with specialized ventilators and drugs that aid in the development of the lungs of premature infants. This affects both healthcare expenditures and healthcare prices. Overall expenditures are going up in part because people are spending money on things that simply didn't exist before, like NICUs. But it also costs more money to buy the things that already existed. Overall demand for medicine is going up because people see that it works. When demand goes up, prices go up. That's a basic law of capitalism. Everything I said about advancing technology applies especially to the pharmaceutical sector. The amount of money we spend on drugs has been going up pretty steadily since 1980, in part due to the introduction of expensive specialty drugs. Multiple sclerosis, for instance, can now be treated with a drug called Avonex, but that costs $5,000 a dose. A couple of charts can illuminate the effect of drug spending on overall spending. So this chart shows you the overall amount of spending on healthcare since 1980. Overall spending is a combination of the light blue and dark blue areas. The scale on the left is in billions of dollars, so as you can see, we are now closing in on spending $3 trillion a year on healthcare. The dark blue area is the portion of spending that goes to drugs, and the light blue area is everything else. As you can see again, the role drugs play in overall healthcare costs has been steadily increasing. This next chart shows drug spending as a percentage of overall spending. As you can see, it doubled between 1994 and 2004. That was the really rough period for drug spending. It has dipped a little bit recently. This is in part due to some very expensive drugs coming off patent so that generic versions of them are available. So, Technology, especially drugs, are a factor here. Another obvious factor is that the population is aging. The leading edge of the baby boom is now 68 years old. Older people use more health care, so the overall amount that Americans spend on health care goes up. And again, increased demand means increased prices. So not only is the overall amount we spend going up, so is the amount we spend for each unit of healthcare goods and services we buy. The next two reasons I want to consider together. The first is that we take too few preventative measures. I'm including here all the lifestyle issues which create healthcare problems for Americans. Too much food, too little exercise, etc. The other is the large amount of unnecessary treatment we get when we think we might be sick. These two work together to create a really inefficient style of medicine. We do too little to avoid getting sick, but once we are sick, we act too aggressively. So, what do I mean when I talk about unnecessary treatment, acting too aggressively? A while back, an article in the New Yorker written by Atul Gawande compared two hospitals, one in El Paso and one in McAllen, Texas. The hospital in McAllen had the highest healthcare costs in the country, second highest in the country, twice as much as the costs in El Paso. Yet the two hospitals were serving the same kind of population, largely poor Spanish-speaking. They were facing essentially the same problems, and the McAllen Hospital actually had worse outcomes than the El Paso Hospital, according to the Medicare rankings. So, why do hospitals in McAllen wind up spending so much more money? Bottom line, the doctors order more of everything. Gawande illustrates this with a conversation he had with some McAllen doctors. I gave the doctors around the table a scenario. A 42-year-old woman comes in with chest pain after a fight with her husband. An EKG is normal. The chest pain goes away. She has no family history of heart disease. What did the McAllen doctors do 15 years ago? Send her home, they said. Maybe get a stress test to confirm there's no issue, but even that might be overkill. And today? Today, the cardiologist said she would get a stress test, an echocardiogram, a mobile Holter monitor, and maybe even a cardiac catheterization. Oh, she's definitely getting a cath, the internist said, laughing grimly. Bottom line is that more hospitals in America are like the ones in McAllen than are like the ones in El Paso, doing more to accomplish less. Gawande points out that in 2006, doctors in the U.S. performed 60 million surgical procedures, which is 1 for every 5 Americans. That's more per capita than any other nation. There are a lot of reasons why up until now too many hospitals have been ordering too many procedures. But one stands out. We have been paying everyone based on how many procedures they perform. Why did the doctors in the previous example order a stress test, an echocardiogram, a mobile monitor, and a cardiac catheterization? Because each one of these things brings more money into the hospital and to the doctor. Now, this is starting to change under Obamacare. Medicare payments are going to be tied to outcome, not the number of procedures performed, and this should make a difference. So, we have improved technology, including new drugs. We have an aging population, poor preventative measures, and unnecessary procedures once we get sick. A fifth cause, recognized by Ronald Munson in his textbook Intervention and Reflection, is an aversion to rationing. This one is in some ways just a different aspect of overtreatment. Countries with national health care plans have national plans to distribute medicine. In the United States, we hate to say no to people. We have to we have to say to people, no, you can't have this treatment. It is unlikely to be effective enough to merit the amount we're going to spend on it. Now, of course, in the US, our resources are still finite, so we do still wind up saying no. We do wind up rationing. But we ration in this backdoor fashion. We ration by the ability to pay. Now this means that people who can pay, either because they are very rich personally or because the government is paying for their health care, buy as much health care as they possibly can. Demand goes up, prices go up. Until recently, this has meant that people in the middle, people who cannot pay for health care themselves but don't qualify for government aid, are priced out of the health care market. The final reason why healthcare prices have been going up is ballooning administrative costs. A 2003 report by the Harvard Medical School and the Canadian Institute for Health Information found that 31 cents on every dollar in the US went to administrative costs, which is double what they spend in Canada. The reason we have such a high level of administrative costs is that we have a large number of insurance companies that are all basically doing the same thing. Each one assesses risks, sets premiums, turns down claims, and designs and markets benefit packages. This is massively redundant. By contrast, in Canada, there is one institution that does this, the National Health Insurance Program. Poor outcomes. The rising cost of healthcare would not be a problem if we were actually getting something for our money. But in fact, we are not. All the money we are spending on healthcare is not making us healthier. This chart compares healthcare costs and outcomes across 5 nations: the United States, Canada, France, Germany, and the United Kingdom. A lot of this information is derived from Ron Munson's Intervention and Reflection, but I've supplemented a lot of it as well. As you can see from the first column, we are paying about twice as much as the people in these other countries. The next 2 columns show common indicators of a nation's health, and as you can see, we come out quite low. The first indicator is life expectancy. Although we are paying more for healthcare than any of these other nations, we have the lowest life expectancy. The second indicator is infant mortality, here measured in deaths per 1,000 live births. As you can see, we are just in a whole other league than the other countries listed. All the nations have a little over 4 deaths per 1,000, and we have a little over 6 deaths. Interestingly, a lot of this is driven by radical disparity in access to prenatal care. Certain segments of the population have an even higher infant mortality rate. For African Americans and for people in extremely rural areas, the infant mortality rate is more like 9 deaths per 1,000. Now, you can't immediately infer from this that our healthcare spending is wasted, because obviously there are going to be other factors that drive down U.S. healthcare outcomes. An obvious problem that we have that the other nations don't have is poor diet and exercise. Because Americans eat more junk food and spend more time on the couch, we have very high rates of obesity, which can both shorten life expectancy and is correlated with problems in pregnancy. On the other hand, as Atul Gawande points out, we have some of the lowest rates of alcoholism and smoking in the industrialized world, so the behavioral factors may even themselves out. We actually need to look at more data to see the effects of healthcare delivery on our healthcare outcomes. These data do some more towards showing that our healthcare delivery system is a cause of bad outcomes. This chart was put together by a team led by Hamilton Moses and is part of an online supplement for an article in the Journal of the American Medical Association. The basic thing measured here is years of potential life lost due to different causes. So, for instance, if a person dies of cancer at the age of 70 and they would have otherwise lived to 75, we say that cancer caused 5 years of potential life lost. Across the whole United States, cancer causes over 8 million person years of potential life lost. In this chart, years of potential life lost, YPLL, is measured as an average for the 34 nations of the Organization for Economic Development and Cooperation. This is basically just a group of rich nations that share data on some important issues. So the numbers here represent how our YPLL compares to the YPLL of these 33 other wealthy nations. And as you can see, our outcomes are consistently worse for almost every potential cause of death. For instance, in 2008, we lost twice as many years of potential life compared to the other industrialized countries due to respiratory disease. What helps us infer causation here is that the effect is seen strongly across every domain. This is how the study authors put it. The breadth and consistency of U.S. underperformance across disease categories suggests that the United States pays a penalty for its extreme fragmentation, financial incentives that favor procedures over comprehensive longitudinal care, and absence of organizational strategy at the individual system level. In other words, we are seeing the outcomes here of a disorganized system that makes it profitable to run a whole bunch of extra procedures. Unequal access. The last part of the problem with paying for healthcare is unequal access. This is the part of the problem that the Affordable Care Act was supposed to address head-on. The process of dealing with the problem has barely begun, however. So right now we are going to look at the problem, where the problem of the uninsured stands, and then in the last section of the presentation we will look at how the ACA intends to fix it. This chart from the Kaiser Family Fund shows the state of things before the Affordable Care Act. Most people got their health insurance from their employer or the employer of someone in their family. Another selection of people got health care from Medicare and Medicaid. A small number of people just bought health care directly. And then here you see that 16% of the population simply didn't have health insurance. That's about 45 million people. For the most part, these are young, lower middle income people. They don't have the kind of quality job that brings health insurance, but they weren't poor enough to qualify for Medicaid or old enough to qualify for Medicare. Given the ridiculous costs of health care, these 45 million people basically did not have access to decent health care. Importantly, 25% of these people were children. This is a Gallup poll from April 7, 2014. As you can see, the number of uninsured people had been basically climbing since the Kaiser chart in the last slide. By the end of the last year, we had a record 18% of people without health insurance. That dropped off precipitously with the rollout of the online health exchanges in the last part of 2013. So it looks like the ACA has been making some progress. Note, though, that this drop just puts us back to where we were in 2009. The problem has not been solved. So let's look at solutions, starting with the Canadian system. This Canadian system is also known as a single-payer plan. It is a national, mandatory health insurance plan. Some people claim that this system is socialized medicine. It is not. It is socialized insurance. This is a national health insurance plan paid for by taxes. We will consider socialized medicine, or something closer to it, when we move to the UK system. This system has many important advantages. First of all, it brings universal coverage. Everyone in Canada has access to health care and access to the same basic level of health care that everyone else does. Furthermore, the Canadian system allows them to emphasize preventative care. The Canadian system has more doctors who work as primary care physicians rather than having a lot of highly paid specialists who come in once an exotic disease is identified. The Canadians have more doctors working with people on a routine basis to maintain good health. Two other advantages to the consumer. There's no paperwork for the consumer at all. You just show your card, and the government works out the rest with your healthcare provider. There is also complete portability. Patients can see any doctor they want, so you don't have to worry about looking up what doctor is on your plan, going to the health insurance company's website and trying to find a doctor that is on your plan, and then calling the doctor and the person answering the phone says, "Oh no, we aren't really on the plan, the website's out of date." Or, "I'm sorry, we're only taking patients in malpractice suits right now." Stuff like that. The final advantage, and this is really important, is the radically reduced administrative costs. A lot of paperwork gets eliminated if you don't have to do it 5 times for each insurance company, and this lowers costs for everyone. There are drawbacks, however, and these need to be emphasized. The main drawback that gets a lot of attention are the waiting lists. Certain kinds of high-tech medicine, MRIs for instance, have waiting lists. The US has a huge number of MRI machines per capita, and if you can afford it, they will give you an MRI if you walk into the emergency room with a headache. In Canada, you won't get referred for an MRI unless there is real evidence you need it. And once you get referred, you have to wait. You have to wait a long time because there aren't a lot of MRI machines, and this is because there's not a huge profit motive for every hospital to buy one. The other things that have long waiting lists in Canada are elective surgeries, things like hip replacement or knee surgery. In fact, these waiting lists are so long that basically everyone in Canada who wants a new hip and can afford to will simply come to America. The final disadvantage to the Canadian system is lower pay for doctors. In fact, Canada has a huge brain drain. Highly qualified doctors will choose to come to America, where they can become specialists and make a lot of more money than staying in Canada being general practitioners. So let's look for a second at how the single-payer system deals with the problems we've been facing. So we talked about rising costs, poor outcomes, and unequal access. Well, costs. In the United States, we pay on average $5,296 per capita on healthcare. That was back in 2002. The Canadians pay about half that. As far as our outcomes go, we saw from the previous slide, and these numbers are just being repeated here, that the Canadian outcomes are significantly better. And finally, because this is a universal insurance program, while we have 16% uninsured, they have 0. All right, let's take a look at the UK system. The people in the United Kingdom are quite proud of their healthcare system, called the National Health Service, or NHS. The NHS was founded after World War II, a time when victory in the war left people quite confident in the ability of the government to manage huge operations, and it has been very popular ever since. These photos are from the huge tribute to the NHS that was a part of the opening ceremonies of the London Olympics. Under the UK system, healthcare providers are paid by the government using money that comes from a progressive income tax, so the rich contribute more. Traditionally, healthcare providers have been paid a salary, but sometimes they are now paid for performance. Private practices and private insurance are also allowed. The same providers can both work for the government and independently. Between 11 and 12% of people in the United Kingdom use private insurance. The system has many of the same advantages as the Canadian system. It provides universal access, so there's no paperwork for the consumer. The system also emphasizes preventative care and does an excellent job of controlling costs, partially through the work of the National Institute for Health and Care Excellence, known by the acronym NICE. NICE is a research body that evaluates the effectiveness of medical treatments and technologies. Often, if NICE decides a treatment is not effective, the government won't fund it, and the patients will have to pay for it out of their own pocket, if they can. Your textbook notes, though, that the NHS winds up paying for an even broader range of services than the Canadian system. The most common complaint recently about the NHS is that they have been essentially too good at controlling costs. The system has been underfunded and, as a result, supplying too little health care to the population. And part of what this has led to is long waits for some procedures. There are also complaints when NICE decides that this or that treatment is not cost effective and people are still clamoring for that treatment. So, how does the UK system deal with the problems we're focusing on? Well, they pay a little less even than Canada. They live a little longer. Otherwise, it is basically the same. All right, now let's talk about the Affordable Care Act. The nation has spent the last few years embroiled in heated arguments about these issues, heated arguments about health care reform. This is a debate that featured a lot of crazy rhetoric, over-the-top fears of death panels, and government takeover of medicine. It also featured a surprising number of people who believed the Affordable Care Act was an attempt by the government to take over Medicare, which is bizarre because Medicare has been from the beginning a government plan. A government takeover of Medicare makes about as much sense as a government takeover of the national parks. So all this finally stopped on March 23, 2010, when President Obama signed the Patient Protection and Affordable Care Act, which was supplemented 7 days later by the Health Care and Education Reconciliation Act, and all of this was in addition to huge amounts of new spending on health care included in the federal stimulus package from the stock market crash of 2007. So what exactly happened here? In the last part of the presentation, we will look at what's been implemented so far and how it's likely to help the problems we've been looking at. The basics. The healthcare plan looks a lot like the Massachusetts plan it was modeled on. You've got mandatory coverage from a mix of public and private sources. Basically, everyone is now required to buy insurance or face a penalty. Those who make less than 133% of the poverty level are covered through Medicaid. Those who can afford to pay a little will get subsidies to buy private insurance. Okay, many measures of the Affordable Care Act are currently firmly in place. First of all, you can no longer lose your insurance if you become sick. Second, insurance companies can no longer turn people down for pre-existing conditions. And finally, there's no lifetime cap on payments. These are the most popular parts of the Affordable Care Act, and it is important to note that they would not be possible without the requirement for universal coverage. The only way health insurance companies can afford to insure all the people who are old and sick is by collecting revenue from the people who are currently young and healthy. And this points to a basic problem with health insurance in the era of modern medicine. These days, most people can count on living to a ripe old age, and when they are that old, they can pretty much count on having expensive health problems. This means that paying for healthcare isn't really like sharing the risk that comes from an unlikely event, which is what insurance is supposed to do. It is more like Social Security, something we all have to do to prepare for our own old age and to help those who are currently old. Okay, so what other measures are currently in place? Well, there are no co-payments for preventative care on new healthcare policies, and a payment advisory board has been set up to reduce Medicare spending. These are smaller measures that haven't been talked about as much, but I think they are a big deal. The lack of preventative care and the proliferation of unnecessary expenses were two of the driving forces behind the problems I focused on in the first part of this presentation. It will be a while before we see if these work, but at least they are targeting the right areas. Okay. The other thing that is now in place firmly is the federal assistance for people in buying health care. The next slide goes into more detail about this. So these are numbers taken from Wikipedia. What you've got here are different levels of income from 100% of the poverty level to 400% of the poverty level. For each of those income bands, there is a subsidy that is available to you. So 96% of your healthcare costs or your health insurance premiums will be subsidized by the federal government if you make between 100 and 150% of the poverty level. Also, your premiums are capped as a share of your income, and what that cap is goes up as your income goes up. You can look over these numbers yourself. What they show is that the requirement that you buy health care is backed up by assistance in buying health care. Other aspects of the Affordable Care Act have not been implemented completely, and this is in large part because of the opposition to the Affordable Care Act. For one thing, there is Medicaid expansion. A crucial part of how the ACA can provide health care for everyone, and indeed require everyone to have a health care plan, is by bringing more low-income people into the Medicaid system. Medicaid is funded jointly by the federal government and the states, but the actual management of the system is done at the state level. Now, Medicaid expansion is being funded entirely by the federal government, which everyone thought would mean that the states would go along with it. After all, this is just free money for the citizens of the state. Who would say no? Well, as it turns out, 19 states would, and their right to do so was upheld by the Supreme Court. This map shows how states are handling Medicaid expansion and comes from the Advisory Board Committee, which is a advisory board company, which is a for-profit medical consulting firm. As you can see, the division falls mostly on red state, blue state lines, and this time Ohio falls on the blue state side. The second contested measure, part of the ACA rollout that has not been going smoothly, are the healthcare exchanges and the mandatory coverage. We'll lump these together. One way the ACA intended to drive down prices was by having insurance companies make their plans available on health insurance exchanges where it would be easy for consumers to compare prices. These exchanges were run by the states, and if the state didn't establish its own exchange, people in that state would go to a federal health exchange. This map is from the nonprofit Kaiser Family Fund, and it shows how states have decided to handle their health insurance exchanges. As you can see, in Ohio, we were supposed to go to the federal website. So the 14 state-run exchanges, originally 15 plus DC, have had mixed success so far. Two very large states have achieved excellent results, New York and California. New York signed up 900,000 people for health insurance and has seen the average price of insurance plans drop 50%. The most successful state has been Kentucky, enrolling 300,000 people, including many in very poor areas of Appalachia. On the other hand, the health exchange in Oregon was such a disaster that they just gave up and sent everyone to the health insurance exchange, the National Health Insurance Exchange. That's not shown on this map. And then there's the federal website, which for a long time had this as its welcoming page. The initial rollout had a lot of problems, leading the Obama administration to extend the open enrollment period. But eventually the site got going, and 8 million people have signed up through the federal or state websites, which fits the goals set by the White House and the Congressional Budget Office. Really, though, the success of the health insurance exchanges won't be known for some time, because we need to see how market forces play out. This is, after all, a capitalist solution to the problem. We are counting on the forces of competition and choice to drive prices down, improve the quality of options, and drive inefficient companies out of the marketplace. The online exchange is merely supposed to speed up the free market process by allowing consumers to make more direct comparisons. So ultimately, we will only see if the system works once we've had a couple years' experience. Time will only tell if we manage to decrease costs, improve outcomes, and provide universal coverage. So what to do now? I suggest that you talk about your experience with the Affordable Care Act on the class discussion forum. If anyone out there signed up or tried to sign up for federal care through the federal website, tell us about your experience. Did you get the deal you wanted? Great. That's all for this presentation, and I hope to hear from you in the discussion forum.